May I call the next speaker, Dr. Shashank Agarwal from Hyderabad. He is one. He is a consultant uro-oncologist and robotic surgeon from Sindhi Institute of Oncology, Hyderabad.
Good morning, everyone. Greetings from Hyderabad. Myself, Dr. Shashank Agarwal, is going to present this paper from Beijing, China, which was published in Journal of Urology in August 2024 issue. So the topic is performing radical prostatectomy without prior prostatic biopsy in a selected cohort of patients evaluated by fluorine PSMA-PET CT and multiparametric MRI. And this was a single center, first ever existing prospective single arm trial. So introduction, prostatic biopsy with pathological confirmation is mandatory before radical prostatectomy in the patients with localized CA prostate. However, prostate biopsy has its own complications in the form of hematuria or urinary retention, etc. Hence, the feasibility of performing radical prostatectomy without prior prostatic biopsy is being well published as well also discussed at various forums. So the intent of this study was to verify the feasibility as well as the short-term prognosis of prostatectomy without the prior prostatic biopsy. Coming to the methodology of the study, the patients with the PSA ranging from 4 to 30 nanogram per ml were selected for the study, and these patients were subsequent underwent 3 Tesla MRI, and if the MRI shows the lesions of Pirates 4 or 5, then these patients were counseled for the surgery straightforward without going the further prostatic biopsy, and the patients who agreed to undergo the surgery without the biopsies were further investigated with the help of 18 fluorine PSMA-PET CT. And the patients with PSMA-PET CT positive lesions with no evidence of T3 or T4 or distant mets and who gave the consent for straight away going for the prostatectomy were included in this study. The exclusion criteria include that the patients who underwent previous radiation or hormone therapy or the patients who underwent prior TRP or prior prostatic biopsies were excluded from this study. Coming to the index tumor definition. So the lesion was considered to be positive on both MRI as well as on PSMA-PET CT, were jointly identified by 2 radiologists and 2 nuclear medicine physicians. And based on these 2 investigations, if there was single co-positive lesion, then it was straight away designated as an index tumor. However, in the presence of multiple co-positive lesions, for each lesions, individual lesion scores was being calculated, which was the combination of Pirates score plus molecular imaging PSMA score, and the lesions having the highest score was considered to be the index tumor, and if the scores matched, then the lesion having the largest dimension was considered to be the index tumor. Coming to the pathological definition of index tumor, the tumor harboring the highest Gleason's score was considered to be the index tumor. However, in case of equivalency in the Gleason's score, the largest volume of the lesion was considered to be the index tumor. Based on the imaging and pathological correlation, the correspondence term was defined as the dominant lesion localizing both on imaging as well as pathology using the 12-region mapping scheme. So the primary outcome of this study was to identify the clinically significant prostate cancer, which was defined as the ISUP GG grade 2 or above, with the secondary outcome was to evaluate the index tumor localization respondence rate as well as to analyze the positive surgical margin. Coming to the results, so this is the demographic profile of the patients. Total only 47 patients were included in this study with a mean age of 66 years. The preoperative total PSA was 10.5 nanogram per ml with a PSA density of 0.24. So the clinically significant prostate cancer was confirmed in all the 47 patients who were enrolled in the studies, and 11 patients, that is 23% of the patients, exhibited adverse pathology findings in the form of extraprostatic extension or SV invasion post-operatively. And when we analyzed the lesion level findings, then total 80 tumor foci were present in the pathological specimen, and out of these 80 tumor foci, 63 lesions were considered to be the clinically significant prostate cancers. However, amongst all the 80 tumor foci, only 57 lesions were detected on either MP-MRI or PSMA-PET CT, and the remaining 23 lesions which were missed on the imaging were mostly insignificant prostate cancers. It means that the ISUP grade was less than 2 or the lesion size was less than 15 mm. So in this picture we can see that this is the index lesion which is focus 2, which was present in the left transitional zone, which was present both in the PSMA-PET CT as well as in the MRI. Coming to the focus 1 lesion, which is present in the right transitional zone, we can see this lesion only in the MRI, not on the PSMA-PET CT. Coming to the focus 3, which is present in the left posterior peripheral zone, it can be also seen, well seen in both the PSMA-PET as well as MRI. However, the focus 4, which is present in the final pathological specimen on the right posterior peripheral zone, was seen in none of the imaging. So the imaging finding for multiparametric MRI, PSMA-PET CT and the combined imaging. So first we talk about the MRI. Total 58 patients were detected to have pyretes more than 3 lesions, and out of these 58 patients, only 55 patients were having the clinically significant prostate cancer, giving the sensitivity of 87 and positive predictive value of 94% respectively. Coming again to the PSMA-PET CT alone, around 55 of the patients were having the molecular imaging PSMA score of more than 1, and out of 55, only 52 patients harbored the clinically significant prostate cancer, giving a sensitivity of 82 and positive predictive value of 94%. When we combine both the imaging, we found that out of 51 patients, all the patients were having the clinically significant prostate cancer, giving a positive predictive value of 100%. And if we considered either of the images, like the on MRI pyretes scored more than 3, or on the PSMA-PET molecular imaging PSMA score of more than 1, then out of total 62 patients, only 56 patients were having the clinically significant prostate cancer, having the PPV value of 90%. So coming to the positive surgical margin. So out of 47 patients, only 9 patients were detected to have positive surgical margin. And in these 9 patients, 6 patients were harboring the PSA of 4 to 10. So in these low risk considered cases, the surgeon tried to perform the nerve sparing prostatectomy, leading to the positive surgical margin. Coming to the limitations of this study, obviously the total sample size was very small, it was just 47, so it limits the generalizability of these findings on a larger cohort, and the routine use of both PSMA-PET CT and multiparametric MRI is unnecessary imaging, and it increases the cost if it is being performed in each and every patient. So to conclude, the combined multiparametric MRI along with the PSMA-PET CT enables accurate diagnosis of clinically significant prostate cancer, and the biopsy-free RARP is safe and feasible in the patients having significant pyretes scoring on multiparametric MRI with molecular imaging PSMA score of 2 without undergoing increase in the surgical margin rate. Thank you.